Nice to have you here. Thanks for giving your evening to us. It's quite important. There are gentlemen in the audience and there are ladies, and ladies in the audience, presumably you have loved ones. That would be fathers, grandfathers, brothers, sons, grandsons, that this might be something of interest. What I'm going to focus on today is where we've come from, where we're going with regards to PSA testing, because there's a lot of, and when I say PSA testing, that means the early detection of prostate cancer. It's either the top or the number 2 most common cause of cancer death in men. It is unequivocally the most common cancer in men. In fact, I'm 62. Sharon was talking about a colleague of ours that we knew who was 60 and how old he was. Well, I'm older than that. And at 62, if we rounded up 100 men my age, took their prostates out and looked in them, about 62% of them would have cancer in them. And that's the same percent that 50% at age of 50, 75% at age of 75. The disease is ubiquitous. Most prostate cancers won't cause harm. However, about 2% of American men, as many as 4% of African American men, will die from prostate cancer. And I will tell you that I'm sure Dr. Wilkes as well, those of us in the healthcare profession, we've boo-hooed, we turn into emotional cripples for a short period of time after our patients pass away. And because I specialize in prostate cancer, I've had this happen before and periodically think about those patients who have passed away. So the question is, as you think about this disease that can potentially take the life of any of us, men, what can be done to prevent that from happening? And that's what I've been doing for about 40 years of my career. So the PSA test is the test that revolutionized the detection of prostate cancer because physical examination for detection of prostate cancer is about as effective as breast self-examination. By the time not to disparage breast self-examination for the detection of breast cancer, but most of you probably know that it was mammography that changed the paradigm and prevented many deaths from breast cancer. But PSA is a protein that's found in the bloodstream. It's made in the prostate, and so the prostate, if you can imagine, is chock full of PSA. It's a protein, and some of it leaks into the bloodstream, and it just so happens that if you have prostate cancer, more of it leaks. So the higher the level of that protein in the blood that can be tested for is indicative of a higher risk of prostate cancer. So I want to take you back to when I was a young resident. This is dark ages. We used typewriters. Some of you don't even know what that is. But these are the dark ages. And in those dark ages, in many respects, it was a very dark age. Because a man with prostate cancer, generally speaking, walked in having lost 50 or 60 pounds, had significant pain, not sure why he had significant pain. Sometimes he presented walking down the street with a spontaneous fracture of his femur, or all of a sudden becoming paraplegic because prostate cancer caused a cord compression of the spinal cord. It was a terrible time, and that's what prostate cancer was up until the 1980s when we discovered the PSA test. And we also understood in the 1980s that it was going to get substantially worse. And the reason for that is that deaths from prostate cancer are very unusual before the age of about 60 or 65. But because of all the wonderful advances of healthcare, if you can imagine cardiac stents, if you can imagine cholesterol-lowering medications, seat belts, all the things that have enabled us in the United States, the median life expectancy of a man is 80. That means that half of the American men will live over the age of 80. All of these advances have pushed the life expectancy into an era where when you get to be 80, your risk of dying from prostate cancer goes up dramatically. And we knew that we had a problem because the number of men of that, whatever your definition of elderly is, I think this one is over 65. At 62, 65 does not, to me, seem elderly, but nonetheless, it increases over time. And you probably know that my generation, the baby boomers, which some of us are baby boomers, we're going to be the ones who will be facing that prostate cancer risk. And as the population obviously gets larger, that will happen as well. So what happened with the PSA test? And it was discovered that if you had a PSA above 4, we're just going to ignore the nanograms per mil, a PSA above 4, your risk if you did a prostate biopsy was about 1 man in 4 had prostate cancer. Eureka, said the medical community. 1 person in 4, if you think about it for a moment, a statin to lower cholesterol, how many people have to take a statin to prevent a heart attack? You know? It's a statistical term that you use in medicine. How many people have to buy a lottery ticket to win the lottery? A lot, right? How many people need to take a statin to prevent? It's about 90 to 100. Which means that most people who take a statin don't benefit. But because a heart attack is so bad, right, we give 90 to 100 people the medication to lower the cholesterol to prevent a heart attack. And most of us, when we talk to our doctor, you know, that's a little bit more than a 1% likelihood we'll benefit. We don't want a heart attack. In this case, 1 man in 4 with that PSA test has prostate cancer. So it's enormous. And if cancers were found at that point in time in the 1980s based on the PSA test, virtually everyone was treated. And lo and behold, compared to the generations before, when virtually every single time you thought you found prostate cancer early, oftentimes by a physical examination, kind of like the old breast cancer analogy, that if you felt a bump, you treated it, but generally speaking, it came back, right? Most of the time that was true for prostate cancer. So all of a sudden we were treating prostate cancers and men were alive free of disease. It was one of those eureka moments and we began to see long-term cures. And cancer rates increased between 1996 to 2012 and mortality, I'll show you in a moment, death rates from prostate cancer since PSA was screening began, fell by 50%. There were men that were alive. Of course, they didn't know, well, some of them knew who they were because they were treated. Men that were alive who were destined to die, who using the PSA test, just like a mammogram, did not die from prostate cancer. That's a pretty cool thing, as they say. We began to use lower PSA levels because some of the men, it was only a 50% fall. It's not good enough, right? More biopsy cores. We began by doing 4 little biopsies, then we increased to more of those. We began doing MRIs. But an interesting phenomenon happened. These were the rates of prostate cancer in the population before PSA testing. Look what happened. Oh my goodness. And what this is called a harvest phenomenon because there's a lot of people out there who had never been tested. You found them in this period of time, but you see the steady state is about 75% more than it was prior to that. So you found more prostate cancers and you were treating more prostate cancers. And so even today, when you get your blood test results back, it looks like this. This is an actual patient. You see there's no names or anything up there. But you see this is the typical lab slip that says PSA. That's the value. That's the normal range, 0 to 4. Above 4 is abnormal. Below 4 is normal. Today, 2016. And I'm here to tell you that as of 2004, we showed that's wrong. And that's why we're here today, because we ran a clinical trial. This clinical trial began in oh my goodness, I had no gray hair, 1991. This study examined this medication. It's a drug called finasteride, also called Proscar, also called Propecia. There may be some young men in this audience who take this or men who have taken it. It's a medicine that has two indications. One is to shrink the prostate to improve urination. The other indication is it grows hair on your head. And so, interestingly, what that drug does is it recapitulates a genetic change that some people are born with. My sister says, I was born with a genetic change that made me have big ears. She said that since I was little. But in people who are born with that genetic change, they don't develop prostate enlargement and they don't develop prostate cancer. And it's one of the very first targeted agents for any disease. It targets just the prostate. The same enzyme is in the scalp, and that's why it prevents hair loss in some men. And because in Mother Nature, if you're effectively born taking, if you will, that medication, you don't get prostate cancer. We began this study, 24,000 men enrolled in the study. About 19,000 were randomized to placebo or finasteride. And oh, by the way, that's a whole other story, not for today. That medication reduces your risk of prostate cancer by 1/3. Principal side effect in men my age is you don't have to get up so many times at night. And people who have male pattern baldness, you grow some hair. But nonetheless, the important point about this is that at the end of that study, every man had a prostate biopsy. And you see that it's not true that the risk of prostate cancer is 0 until you get to 4, and it goes up to 25%. Just like any other biologic measure, it's not all or none. It's not a pregnancy test. Below 4, no cancer. Above 4, risk of cancer. It's directly related to the risk. So a PSA of 3, your risk of prostate cancer is about 25%. And your risk of aggressive prostate cancer is about 4 or 5%. The aggressive prostate cancers are the ones that kill people. So the conclusion was, oh my goodness, there's a lot of cancers out there, we can find them, and there's a lot of them that we were doing lots more biopsies. And so as a result of all of this, what happened was the United States and in Europe, this is very important to understand, decided they were going to test to see whether or not PSA testing, screening and treatment would be useful to reduce the risk of dying from prostate cancer. And so the only way to do that, in fact, just like mammography screening, large randomized trials of doing mammography versus no mammography showed that mammography lowered the risk of dying from breast cancer. Large clinical studies of CT scans of the chest in smokers showed that there was a reduction in risk of death from lung cancer. Same kind of studies, 2 studies independently, one in the United States, one in Europe, were conducted, randomizing men to screening versus no screening. Importantly, very important distinction between these 2 studies. In Europe, at the time it began, there was no PSA testing ongoing. None. Europe had not adopted that. In the United States, PSA testing had already begun. And so when you're randomizing people to screening versus no screening, the norm in Europe was that the general population was not being screened. In the United States, you had a problem. A lot of people were already having PSA testing. And so the ultimately results of these trials that were published 5, 6, 7 years ago, one is the US study. They were both published back to back in the New England Journal of Medicine, which is kind of like the most important medical journal. The US trial showed that there were more prostate cancers found in the group that were being screened. But if you look at this, these are the men that were not being screened. This is year over year. There's a fair number of those. A slight increase in the ones that were being detected in the screening group, but a lot of prostate cancers detected in the people that were not being screened. No difference in death rates between the 2. The US trial concluded that there was no reduction in death from prostate cancer from PSA testing. The European trial, on the other hand, this is the same issue of the New England Journal, showed that there was a reduction in risk of death from prostate cancer. This is the risk of death from prostate cancer in those that were being screened. You don't see it at about 6 years. You begin to see the difference at 8 years. By the time you get out to 14 years, you begin to see that those men who were destined to die of prostate cancer had previously been diagnosed, and there was a reduction in risk of death. Again, most prostate cancers, if I am found to have a prostate cancer, and if I'm destined to die from that prostate cancer, it's generally not next year, most of the time. Generally, it's years later. And that you see that difference in the European trial. The problem with testing for prostate cancer is also not just the fact that there are many men that will have it that may not die from it, also the treatments have some side effects. Now, fortunately, the treatments that I remember in 1980 are much better today. Surgery's better, radiation's better, but even in the best of hands, there can be urinary side effects, difficulty emptying the bladder in men getting radiation, difficulty with leakage in men, urine leakage in men who have had surgery, or sexual problems. And the reason why there are sexual problems, and I'm delighted to hear that this group is going to be speaking on sexual function, which is very, very important. Now, those of you who are young in here may think, they're too old. Trust me, sexual function is important at virtually any age. The reason why sexual function can be affected in prostate cancer is the erection nerves are on the surface of the prostate. That's why colorectal treatment and prostate cancer treatment and bladder cancer treatment can affect sexual function. And you see the really substantial decline in sexual function that you can see in people who have been treated for prostate cancer. So when we think about the trade-offs of detection of prostate cancer, the number one reason why we want to find the disease early is not to simply find the disease. We want to find the disease early, to find disease that is ultimately going to cause the patient harm and prevent that from happening. And at the same time, for those people who are destined not to have problems from their prostate cancer, to try to avoid treatment because of this, because urinary, sexual, and other potential side effects that you can have. And so that's really the subject of this presentation is how do you focus it and laser shoot the tumor that's going to cause problems in a fashion that prevents problems and trying to minimize side effects of the screening process and others. Nonetheless, because of those two studies, the US study that showed no difference in death rates, an organization called the US Preventive Services Task Force. Who's heard of the US Preventive Services Task Force? Very few folks. It's a pseudo-government body that makes determinations on what your family practice doctors should do. They look at the evidence, they sit in a room, and they act as surrogates of the general public, trying to determine what's best for you. The interesting thing about that is that US Preventive Services Task Force has a dramatic impact on what primary care physicians and other physicians do and what they're paid for. Okay? They are making decisions for you. And they gave PSA testing a D. Not that it could be offered, not that it's good to be done, like mammography is recommended, blood pressure checks recommended, glaucoma screening recommended, PSA testing, it was recommended not to do it based on that information. Now, it kind of makes sense because if you simply look at the US study, you come to the conclusion there's no benefit. Remember I showed you that slide that shows the death rates are the same. So why would you do it? European study shows about a 20-25% reduction in death rates, which by the way, is precisely what you see with mammography. Precisely what you see. But the US study showed no difference. And so as a result of that US Preventive Services Task Force, that's what's happened to PSA testing. It continues to decline in the United States. And Part of that is because people have looked at the Preventive Services Task Force recommendations, said we shouldn't do it. Some of it also is healthcare systems and payer models. It's increasingly such that physicians in the United States are either incented to do things that people think they should be done, or they're de-incented to not do things that people think that ought not be done. And so through a combination of effects, you've seen a reduction in PSA testing and in prostate cancer detection. But the kind of the gorilla in the room is this simple statistic. This is when screening began. That was the death rate from prostate cancer. As screening continued, look what happened year over year over year, a fall in death rates. It's about 50% fewer death rates from prostate cancer during this period of time. And the question is, how can mortality have fallen? So if one is a nihilist, and we're going to come to what we think is, if you bear with me just for a few minutes, we're going to come to what the future looks like. But it's important to say, why is the death rate falling? Now, some people, and there are some companies that make medications that in certain circumstances dramatically reducing the risk of death from prostate cancer. And so one of the possibilities could be that it's not early detection. It could be that now when a person shows up with widespread prostate cancer that we know is going to take their life, we now have a quiver of arrows that we can shoot at that prostate cancer. And many of those are quite effective. They are blockbuster medications. The only challenge with those is that when you look at the improvement in survival with these medications, on average, those are months. 2 to 4 to maybe 5 months. The very best is a year, but that's pretty early use of chemotherapy in very advanced disease. So the challenge with these advances that we've seen is that the advances that we've seen to treat advanced prostate cancer don't get you 50% reductions in mortality. And generally speaking, a man who shows up who has not been screened for prostate cancer and presents with symptoms from his disease, most of those men will ultimately die from their prostate cancer. So these allow men to live longer, but they ultimately, their ability to cure the disease, for the most part, is not there. Also, better treatments with surgery and radiation don't get you there either. None of these have been demonstrated to improve outcomes. And I'll just kind of, for purposes of time, I'm going to skip through these, other than to show you that if you find the disease early, you can substantially, this happens to be a surgical series, but it's been shown with radiation as well, that if you get the disease early and you treat it, you can see a lower death rate. So this is the death rate with treatment, this is the death rate without treatment for more aggressive localized, oh shoot, wrong button, here we go. So people have looked to determine what's going to happen if PSA testing or early detection efforts for prostate cancer stop. And the National Cancer Institute's Cancer Intervention and Surveillance Modeling Network, it's probably the premier group of statisticians who look at the evidence, synthesize it, and predict what the future will look like, have said, for example, here are cancer deaths. These are risk of development of metastatic disease. That's where it spreads to the bone and causes all of those complications. These are two different models. They're basically the same. This is where we are right now. This is spread to the bone. If PSA testing continues, that's the risk. That is the number of men that will have spread to the bone. If you stop it, it will go up again. Very clear evidence that that's the case. Nonetheless, that governmental pseudo-agency has been telling physicians, don't do that anymore. And again, we have this problem that the number of men at risk of dying from prostate cancer is exploding in our country. So the old way of doing that, doing PSA testing at a population level, looked like this. You look at all the men, say, over the age of 50, which is the risk age, about that, And they would get a PSA test every year. And if the PSA was less than 4, they'd be sent home. If it was above 4, they'd be sent to the doctor. They'd have a biopsy. All of them would have a biopsy. And if they were found to have cancer, all were treated. This is the way the disease was approached. It was that eureka observation. But in retrospect, based on 30 years of information, it was naive. That's not the way we do it today, but that's the way it was. So in 2016, are we more sophisticated? Obviously, yes. How did that happen? Your taxpayers' dollars that go to the federal government, that nobody wants to go there, nonetheless fund clinical studies, incredibly important discoveries that come back and give us the information to make very smart, precision recommendations for every single person who walks in the office. So remember, this is that PSA test, 5, abnormal, less than 4 is normal. Remember I told you, now you know that's just flat out wrong. The higher the PSA test, the higher the risk. The higher the PSA test, the higher the risk of that lethal cancer, right? So let's go back to this study. This is that same study. The thing I didn't really emphasize very much is it's the only study ever done in the world in which at the end of the study, every single person had a prostate biopsy. We knew whether the men had prostate cancer or not based on a biopsy, and every single person, whether their PSA was 0.1, 2, 4, 8, 10, and so forth. We also knew a lot of other things about them. We knew their age. We knew their family history, whether they had a family history of prostate cancer. We knew their race and ethnicity. Just remember I told you African American men have a higher risk. Hispanic men have a lower risk. Asian men have an even lower risk than that. We knew what their prostate examination was like, whether they had an abnormal prostate examination. And so we developed a tool that integrated all of this. And I'm just going to skip through certain things here. So this is the study that we published in about 2006. And it's the first study that looked at, and this is based on almost 6,000 men, all of whom had had a biopsy. All of them had had multiple PSA tests over 7 years. Actually, they had to have it at least 5 years worth of multiple PSA tests. And we developed a method of putting all the information together to predict an individual man's risk. And it turns out the things that matter are the prostate examination, the age, race, ethnicity, family history, and whether they had had a prior biopsy. Because if you had a prior biopsy that was negative, you had a lower risk, right? Just like anything else. And so before we go any further, it's important to understand the prostate cancer emojis. And we borrowed this way of showing it to patients from the ENT literature, that they develop systems to help mothers with young children know that if they had a child with a little bit of fever that was pulling on their ears, what would happen back in the old days? Everybody got antibiotics, right? And it turns out that if you treat everybody with antibiotics, you actually make more kids worse. So helping moms understand that, very rarely does the child benefit, and sometimes you make it worse. So the emojis here indicate a man who comes in to see you that you think may have prostate cancer, and you're trying to decide whether to do a biopsy. Who do you want to biopsy? Everybody with prostate cancer and find that prostate cancer? No. You want to find which prostate cancer? The prostate cancer that's going to hurt him in his lifetime, that's going to spread, cause symptoms, or cause problems. If there's a prostate cancer that's not going to cause him a problem in his lifetime, just remember, most of us, I have more than 50-50 chance of having prostate cancer in my prostate, but 2% risk of dying from it. Does it help me to find a slow-growing prostate cancer that I'll never know about? Absolutely not. What happens? You might get treated, right? You get labeled as having prostate cancer, and then it goes into your health insurance or your life insurance. You want to get new life insurance. You have to come see me every 6 months, right? That's no fun. Yeah, well, maybe it's Starbucks or something like that, but that's no fun. So, and then the anxiety. The moment that you're diagnosed with prostate cancer, you are a cancer survivor. And it's not fair to the person who's destined never to have problems from their prostate cancer to say you have prostate cancer, right? And so you have to change some of your thinking. You have to change some of your thinking that all cancers are bad. And we know that that's not true in many organ sites. That's not true skin cancer, melanoma, thyroid cancer, some lung cancer, some pancreatic cancer, some breast cancers. It just happens that in prostate cancer, it's much more common. Most prostate cancers won't cause problems. So the concept is, who do you want to biopsy? Do you want to biopsy the man in whom the biopsy will be negative? No. If you've ever had a colonoscopy and you wake up the next morning after the colonoscopy and the gastroenterologist says, "Congratulations, Dr. Thompson, it was completely normal." That means that the night before was completely unnecessary. And the only people who laugh know what it's like to have a prep for a colonoscopy. So you don't want to do a negative biopsy. That's wasting money, potentially hurting your patients. You don't want to do a biopsy that will find an inconsequential cancer. You want to find this cancer. This is the cancer that poses the patient a risk of dying. And so the question is, how can you find that? That study helped us to develop the PCPT risk calculator. This is it. If you Google prostate cancer risk calculator, it's always the top hit. It gets hundreds of thousands of hits. And on this side, you can see, you can fill in the race, there's race, ethnicity, age, PSA, family history, rectal exam, prior, whether the person's had a prior biopsy. You notice over here, all of this stuff over here, oops, shoot, didn't mean to do that. All this stuff over here are additional tests, and I'm not going to spend any time on that, but trust me, there are other tests that you can do that help improve the detection. And so you can, for example, this 55-year-old Caucasian man comes in because last year, for the last 10 years, his PSA has been 0.2, and now it's 1. It's gone up 5-fold, and he's scared that he may have prostate cancer. So you put in his information, his physical exam is normal, you put all that information in, that's what it looks like in his particular individualized assessment. In his particular case, there is a 1% risk that he may have an aggressive prostate cancer. On the other hand, there's an 11% risk that he will have a slow-growing cancer detected. Remember, most of us have those in our prostates. And in his case, there's an 11 times greater likelihood you'll find that, and he will be labeled as a prostate cancer patient the rest of his life. And the other side about it is that 88% will have a negative biopsy. So you'll only potentially help one person in 100. And oh, by the way, this definition of aggressive prostate cancers is a very conservative definition. Maybe half, maybe a quarter of those people may benefit. So in this particular circumstance, doing a biopsy will help one person in 100. It may be one person in 500 are helped. On the other hand, 11 people in 100 will be not helped, but labeled as having prostate cancer, potentially not helped. And then 88% of the people will have an unnecessary test. On the other hand, let's take a 72-year-old African-American male, and let's say he went to his primary care doctor because his dad had prostate cancer, and his primary care doctor said, "I read the U.S. Preventive Services Task Force recommendations and says we shouldn't do PSA testing," which is happening today. The gentleman, however, has read about this and said, "I'd like to have a PSA test." It comes back 6.5, goes to see a urologist. The urologist feels a bump on the prostate. What do you think his risk looks like? Looks like that. He has almost a 40% chance, a 2 in 5 chance of having a life-threatening prostate cancer. He has a 19% risk of a low, and he has about a 40% chance of a negative biopsy. So you see, it's very small differences in PSAs, but huge differences based on other factors as well. We don't use PSA alone. And the analogy to this in the cardiac field or in the heart health field is, can you imagine taking, let's say that cholesterol less than 200 is normal and a cholesterol above 200 is abnormal. Let's just say that that's the threshold. And a man who comes in with a cholesterol of 199, you say, you're fine, go home, come back to see me next year. And another man comes in with a cholesterol of 201, and you say, I'm going to put you on medications. Say, maybe that's okay, but let me just change it around a little bit. Imagine that that man whose cholesterol is 199 is obese, has high blood pressure, has diabetes, and every single person in his family died of heart disease. And he's sedentary, doesn't exercise. The man whose cholesterol is 201, everybody in the family lived to be 110, never smoked, no blood pressure problems, so forth, skinny as a rail. That's the naivete of simply looking at a PSA test and ignoring the other features is like saying, I don't care if you smoke, as you're looking at somebody's cholesterol, right? Doesn't make any sense, doesn't make any sense here. And the nice thing about it is that that investment in that scientific research has revolutionized this. On the other hand, you can have some ones that are kind of in between. And this is, I won't say this is fun, but this is where medicine becomes that incredible opportunity for physicians and patients and families to interact. This is a more classic example of a 60-year-old Caucasian man, no family history, PSA is a little high, and gets sent in to see a specialist in prostate cancer. You run his numbers, this is what it looks like. About a 5% risk of an aggressive cancer. Remember, I'm telling you, it's a kind of a conservative definition. So not all of these are going to cause problems. Maybe half. So probably around 2 or 3 people would benefit. On the other hand, 17% of the men will be found to have one of those slow-growing cancers, which leads to those probably not the best consequences, being labeled and so forth and so on. And then a lot of guys will have negative biopsies. The fascinating thing to me is that 2 men, they're oftentimes with their spouses. One man, you say, about a 5% chance that you have an aggressive prostate cancer, and that's probably an overcall at maybe 2 or 3%, but there's the downside of the detection of inconsequential disease and the unnecessary biopsy. That's you. And another man, you come in and you give them the exact same information, and one man says, I want a biopsy, and the other man says, I think I'll recheck my PSA next year. And the interesting thing to me is that's called personalized medical care based on the priorities and the preferences of patients. And some people say, well, patients can't make that decision. It's called risk assessment. You do this every day when you go to buy a major appliance. You go to Consumer Reports, you look it up, you say, is it more expensive? Is it more buying a car? All those sorts of things. So people make these decisions all the time, and properly explained, fascinating to me, people will make an independent decision and are very, very satisfied with it, and it's right for them. So there are some other advances. We're not going to go into the some of the other advances that are just astonishing things that are happening. But understand, most men will not die of prostate cancer. Wouldn't it be really nice to only test those men who are destined to have problems with prostate cancer? Wouldn't it be nice for those of us, most of us in the room, colon cancer, will never develop colon cancer and never die from colon cancer, right? Wouldn't it be nice if we could predict who was never going to have colon cancer and never have to have a colonoscopy? I mean, other way of saying that is, wouldn't it be nice for breast cancer, there's some ladies in the room, to be able to predict those ladies that will never get breast cancer? And you can skip the mammograms and the anxiety and all those things. Please don't do that. Please do that today, because we're not there. But the interesting thing about prostate cancer is it turns out you can do that. And we have a study going on in South Texas, San Antonio and South, actually it's several states. It's about 5,000 men who we followed since 2000. And they're participating in a study that helps us assess blood tests and other tests for prostate cancer. And we know what their PSAs were back in 2000. The thing I find interesting, these are called sextiles. So this is the bottom sixth, second bottom sixth, and so forth, the PSA. about half of the American men have a PSA less than 1, and about half have a PSA above 1. So you see the bottom 3, the highest PSA is 1. It turns out that if your PSA is 1 or less, you have almost no risk of prostate cancer out to 12 years or so. And so the take-home message from a population health standpoint is that in general, again, nothing is 100%, other than, as I love to say, the love of God. Other than that, nothing is 100%. You can truly go out and spend $1 for a lottery ticket and win $400 million. Most of the time you won't. But if your PSA is less than 1, your risk of prostate cancer is extremely low at 10 to 12 years. So from a population standpoint, instead of having it checked every year, if your PSA is 1 or less, you can have it checked every 10 years. And you can be reasonably certain that that's really all that you need. If it's above 1, then perhaps every year is the best way to do it. The other thing to understand is that if you happen to find those low-risk tumors, the nice thing about it today is many of those patients choose, instead of having it treated with those urinary, sexual, and other side effects and the cost associated with them, to simply observe those. Remember, most of us don't know it, but we're observing our prostate cancers. We have them, but they've not been diagnosed. So if you put a man on surveillance, we have about 1,400 folks on active surveillance. This is the Hopkins experience. This is one of the longer experiences in the United States. That's the risk of prostate cancer death approaching 20 years. So for one of these slow-growing prostate cancers, if you simply observe it carefully and only treat it later on if there's evidence that the cancer is growing, the risk of problems from the prostate cancer is between 0 and 2%. And that's kind of cool too. You can avoid treatment for those. So you see where we're going today is we're going towards screening the people that can be helped, only biopsying those people that we think have a greater likelihood of being helped than harmed, and then treating those people who are most likely to benefit from treatment. And I'm just going to skip through this for the purposes of time. I want to take you back just for one kind of closing comment. Maybe have a few minutes for questions. Remember how the U.S. Preventive Services came to the conclusion that you shouldn't do PSA testing. It's based on that U.S. trial that suggested that screening didn't reduce the risk of death from prostate cancer. But you remember what I said earlier is that when that study was conducted, at many cities in the United States, virtually every single man over the age of 55 was getting PSA testing. So if you remember that study, a man who went in would be randomly assigned to PSA testing in the study, and if he was in Europe, if he was not getting PSA testing in the study, he was getting no PSA testing. In the United States, in many of these cities, if he was randomly assigned to PSA testing, he'd get it on a regular basis. And if he was randomly assigned to not getting it, what was happening in the community? He was getting PSA testing. So what would you expect would be the difference in the mortality? Virtually zero. And we've subsequently found, and I just want to, so this was the, subsequently, I want to just show you, this is an example of at one of the sites in the United States where they're doing a population-based PSA testing in the same city that the study was ongoing. And I think it's here. Do I have it in here? Where is it? Well, it's not in there, sorry. But they've looked at it subsequently, and it turns out, if you look at the study itself, there turned out to be more PSA testing in the men who were randomly assigned to not be tested than the men who were in the study. So the current options today with regards to early detection of prostate cancer is to say, we're not going to do it. And we will hope that that Preventive Services Task Force was right, even though that since the early detection of the disease began, there's been a fall by 50% in the death rates. The other possibility is what I think I've tried to explain to you today, is that we're far more sophisticated about this. We can predict the man who's at very low risk of prostate cancer, PSA less than 1, send him home for 10 years. The other men, we can do PSA testing on a regular basis, look at his individual risk. By the way, at our laboratories across town, not too far from here, we don't have time to go into this, but the sophistication of the testing is, I will point out one of the tests that we're looking at. Dr. Tim Huang, who's the chairman of molecular medicine, has discovered that after a prostate examination, when a man urinates, the first ounce of urine has about 30 prostate cells in it. We can identify those. And using some very sophisticated technology, he can pick out those prostate cells, put them in a computer. Who remembers Pac-Man? The things that probably nobody, there's a few of us remember Pac-Man. A computer, one of his laboratory technicians drives the cell across a miniature plate and puts it in a microscopic well, and then does full genetic analysis on each individual cell. It's astonishing. And what we're trying to develop is a test that will get rid of prostate biopsies. And all you do, guys, I'm waiting for this myself, pee in a cup. Wouldn't that be nice? So the technology is the things that we can do today, right, Dr. Wilkes? We could have never visualized this. The sequencing of the human genome took months, hundreds of sequencers all working simultaneously, and one statistician that looked at it. Now our problem is we have a few sequencers that put out data so fast, we don't have the storage capacity to handle it. We have to have large fiber optic cables to take all the information. We have to have a whole building full of statisticians to analyze them, and supercomputers. So the things that we can do today are truly astonishing. And so we can leverage the information to help identify that man who is most likely to have problems from his disease, back it up, find it early, intervene, and prevent that from happening. And I'll just kind of close with that. Oh, just one more thing. This is not unique to prostate cancer. This is my friend Laura Esserman. I don't know if you know Laura. She runs the breast cancer program at the University of California, San Francisco. They are doing exactly the same process in breast cancer, and they're looking at the usual kind of screening, the annual mammography, versus what's called risk-adapted screening. Same thing happens in breast cancer. There are women who are at greater risk that need to be screened more frequently. We do it in colonoscopies for people with family history or certain genetic defects that predispose them to colon cancer. We're beginning to learn that this can be done in other diseases as well. And so I'd like to thank Dr. Wilkes. She's my heroine. She does all this for you, gives up all of her time to make sure that the community is educated in this, and I'd like to thank you all for joining us this evening. And, oh, I'm fine. Okay. Any questions? Yay for you. Yes, ma'am.
So you said the digital rectal examination affects the reading?
Can you restate the question too?
Just a little louder. I'm kind of deaf.
You said that the rectal examination
Is
affects
this for him?
the reading?
Oh, so the question is, does the rectal examination affect the PSA test? In general, no. However, there are some things, just remember, imagine the prostate's really full of PSA. Riding a bicycle, rectal examination, bowel movement, the prostate sits next to the rectum, those sorts of things, the likelihood they'll cause a significant change is quite low. But in folks in the medical profession, if you have a prostate infection, a tremendous inflammation in the prostate and fevers and so forth, please don't draw a PSA. It gets the patients all upset because when you have inflammation, cell walls break down, PSA leaks out, and you get sky-high readings, and it leads to palpitations in the patient and unnecessary visits, and then they come back 6 months later and it's back normal again.
So we can do the rectal exam.
Yes, ma'am.
Then take the test.
Yeah, I mean, if you want to be absolutely pristine about it, I mean, sexual intercourse the night before, you can abstain from that. But in general, the likelihood you're going to substantially change the PSA with any of those is unlikely. And perhaps a better answer to that is, if you're uncertain, person, and I've seen this happen so many times, person has every year PSA 1, 1, 1, 1, every year 1, 1, 1, and then all of a sudden it goes up to 5. Somebody does a biopsy and finds a little bitty slow-growing cancer. The patient says, well, maybe I'll just watch it. What do you think the next PSA is next year? 1, 1, 1, 1. And just like blood pressure, if you're in traffic and you come to your doctor's office, or you circled around and can't find a place to park, and and you come in and you're all flustered and they check your blood pressure and it's sky high. PSA can do that for reasons that we don't understand. I've seen patients in our large, long-term studies. In fact, one patient I'll never forget, 2, 2, 2, 2, 20. 2, 2, 2, 2, 2. Patient called up and said, obviously it was an error. Well, we have biorepositories. We have about 70 freezers completely full of millions of samples. We pulled that sample out. It was 20. So you can get these little spikes. And so one important thing is never act. No physician would treat a patient's blood pressure with one blood pressure reading. You should never make a decision based on a single PSA reading. And so oftentimes people attribute those spikes in PSA to a rectal exam. It probably was unrelated. There are some things that can happen in the prostate cause it to leak acutely. Just repeat it. You all have been fabulous. Thank you very much for joining us.